So I'm Jess Maxwell. It's great to meet all of you. I'm really excited to be able to talk to you guys today about my favorite topic, which is operating on neuroendocrine tumors. I don't have any very important disclosures. So I'll try to kind of walk through how I think about these cases and how we get from your first clinic visit to the operating room. And so in general terms, we have to figure out what it is that you have, where it is in your body, and then what we're going to do about it. So as Dr. Paulson alluded to, a lot of patients arrive at my clinic having gotten a CT scan in some emergency room for their kidney stone, for abdominal pain, and then lo and behold, there's this new thing that the radiologist points out. A lot of times, even though the imaging is inadequate for surgical planning and things of that nature, it can give us clues to your diagnosis. So for patients who ultimately are diagnosed with small bowel nets, often what we're finding on these imaging studies is this spiculated mass in the mesentery. So that's that kind of sparkly or spiky looking thing, which is actually a clump of lymph nodes with cancer cells in them. For patients with pancreas nets, that's that image on the bottom below the small bowel imaging. You can see that there's this almost perfectly round thing in the pancreas that shouldn't be there. Now, we need a contrasted study to really say much more about this, but that looks a lot different than anything else that exists in the pancreas. So that's our first clue that this is a neuroendocrine tumor. About 25% of patients are going to have some type of imaging of their liver, maybe an ultrasound because you had gallbladder issues, maybe you had abdominal pain, and then lo and behold, there are these spots that weren't there before. And so we make the diagnosis of neuroendocrine tumor by ultimately biopsying these spots, and then we have to go look for where this tumor started. So to kind of drill down on a patient's diagnosis, we need better imaging. And as Dr. Paulson alluded to, CT scans really are kind of the imaging study that we rely on the most. But really importantly, we need a CT scan with IV contrast. And as a surgeon, I want it in multiple phases. And this allows me to see these tumors much better and understand their relationship to the blood vessels and also different biliary structures in your liver and pancreas. I rely on MRI for patients who are on the runway for an operation who have spots in their liver. MRI does a better job of identifying small lesions, and it can tell me exactly where they are and how many there are. I would say in at least 50% of patients where I have even a good quality liver protocol CT, if I get an MRI, I'll find more lesions that will change how I think about the operation. In almost every patient that goes to the operating room, we're going to get one of these dotatate, gallium scans, a copper scan, a PET scan, so that I can figure out where all of the tumors are. In patients with pancreas neuroendocrine tumors, those PET scans are most likely to highlight lesions in the liver that I might not have detected on the CT scan. For patients with metastatic small bowel neuroendocrine tumors, it's really important because this tumor can travel to a lot of different spots. Yes, the liver, but also lymph nodes. And not just the lymph nodes in the area right around where the primary tumor is located, but in lymph nodes that are along your aorta, in lymph nodes that are sort of tucked under the vessels that bring blood to and from your kidneys. These are accessible with an operation, but I have to know about them before we get in there. Invasive testing isn't always used, but it can be helpful in some cases. For patients with pancreas neuroendocrine tumors, particularly patients who have cancers, other types of cancers, and maybe those cancers have spread, EUS, meaning a scope down your throat with an ultrasound to look at the pancreas, can be helpful because we can get a biopsy. So for instance, I have quite a number of patients who have metastatic renal cell carcinoma. Those tumors look very similar in the pancreas. And so if it's important that I understand the diagnosis because it's going to change whether or not I offer an operation, then the EUS with an FNA is going to be helpful. Colonoscopy is something that I strongly encourage/demand in patients with small bowel neuroendocrine tumors who are going to go to the operating room. And the reason for that is because when I get in there and I'm feeling every little inch of your bowel and I've got my hands all over everywhere, If I have my hands on your colon and I feel a polyp, now I don't really know what to do. Is it important that I remove that segment of colon? Is that a benign polyp? All of these questions could have been sorted out with a colonoscopy before we get to the OR, and so I think it's really important that we have that screening tool in place before we roll through the doors. Is a biopsy required? Not really. For the most part, imaging is really helpful to identify what this tumor likely is, and as long as identifying the tumor isn't going to change my surgical decision making, then I sort of go in, remove it, and let pathology sort out the details later. So the next question that we have to ask ourselves once we've figured out what this is and where it is can we take it out? A lot of this is going to be dictated on the anatomy, right? So where is that clump of lymph nodes in the small bowel mesentery? Is it on a non-negotiable vascular structure, right? There are some arteries and veins that you can't lose, or you can only lose a certain segment of them before we end up taking more bowel than we can comfortably leave you with from a quality of life standpoint. We have to think about tumor burden. So Dr. Paulson again alluded to this kind of percentage cutoff, right? When we look at all of the tumors that exist within you, can I, as a surgeon, remove at least 70% of those? If so, then it's probably reasonable to consider an operation. And then, of course, you got to be fit for the operating room. Can you get through an operation? Do you have heart and lung problems that might prevent us from safely doing a surgery? Are you healthy enough not only to get through the surgery, but what happens if we have a complication? Can we get you through that? And then patient support is crucial. We can often do the operation, get you through the hospital stay, but you need people around you that can help you get through all of the aftercare that's going to be required. Are you going to have chronic diarrhea? Are you going to have to be able to alter your diet and have people cook different things for you because you had your pancreas operated on? All of these things are better when you have help. And then probably the most important question that we have to ask ourselves is, should we operate, right? So maybe it's entirely possible to remove that tumor. And so we have to ask ourselves sort of what is our purpose for going to the operating room? Delightfully, in some cases, we can offer cure, right? So if your tumor is located in the pancreas and maybe the lymph nodes around it, we can remove that thing and you're going to be cancer-free. Similarly in the bowel, if we find something that is in the small bowel, it's only gone to the lymph nodes, we can remove it and hopefully cure you. Surgery can maybe help if you have symptoms. Sometimes those symptoms are caused because your tumor is physically causing problems with your anatomy on the inside. Sometimes those symptoms are due to the hormones that these tumors are famous for. Surgery can help with those, both, in some cases. Surgery can hopefully prevent future complications. I'll talk a little bit about the study that's really kind of driven our philosophy behind this at Anderson, but I think intuitively it makes sense. And then I think importantly, and the way that I like to think about it for patients with metastatic disease, is surgery can hopefully kick the can down the road in terms of saving those fancy medical therapies of Dr. Paulson and Dr. Halpern. We can put them in the back pocket, and we can save them for later when maybe you're not a surgical candidate anymore or your disease has spread to places where I can't pluck it out. So when we think about removing tumor for cure, in patients with small bowel primaries, the most important things that we think about are, where are the lymph nodes? Can I save enough bowel, right, and not have to remove a ton, which is all dictated by where these lymph nodes are sitting, and how much bowel am I going to leave you with? For pancreas primaries, we have a few more rules, and so we can kind of make some of these decisions before we even get to the operating room. Pancreas tumors, it's suggested that we remove them once they hit 2 centimeters. And you can ignore the Kaplan-Meier curve, but attend to the table down below. And you can see that the reason that we have set that 2 centimeter cutoff has to do with the likelihood that these tumors have spread to the lymph nodes around the pancreas or to distant places like the liver. So once they hit 2 centimeters, right, there's a 40% chance that we're going to find metastases. That's way different than pancreas neuroendocrine tumors that are less than 2 centimeters, right? That risk is around 7%. Other things that we think about, particularly in patients who have these tumors that are like 1.5 to 2 centimeters, is it growing over time? Maybe it needs to come out. Is it pushing on the pancreas duct, maybe causing you pancreatitis? Another good reason to take these tumors out. And then we'll talk a little bit about how vascular involvement or involvement of the blood vessels might change our thoughts about things. When we're operating for cure, there are sort of some standard operations that we offer, particularly for patients with pancreas neuroendocrine tumors. If your tumor is located in the head or that first part of the pancreas, we're going to offer you a Whipple procedure. That means I'm cutting the pancreas, I'm cutting the stomach, I'm cutting the bile duct, and I'm cutting the small bowel, and then we're reconnecting all of your plumbing with a piece of small intestine. For tumors that are in the end portion, the body or the tail of your pancreas, we're going to offer a distal pancreatectomy and typically a splenectomy. The reason we're taking your spleen with it is because the lymph nodes that those cancer cells are most likely to go to first are located right around the splenic vessels. And I can't take those lymph nodes out unless I take the spleen with it. PNETs are really interesting when it comes to vascular involvement, and they grow really differently than pancreas adenocarcinoma. So pancreas adenocarcinoma, when it's kind of situated amongst your artery and vein in the mesenteric root, it's going to kind of wrap around the blood vessels and squeeze it off. And so when we do the Whipple that has vascular involvement, we're typically taking out a piece of your vein in the middle. And we can anticipate that preoperatively. For PNETs, it's kind of interesting. PNETs like to stick this knuckle of tumor into the vein, right? So my job then is probably not going to involve removing a segment of your vein when we do the Whipple procedure, and we can identify this preoperatively, but I can actually just make an incision over the vein, pop that little knuckle of tumor out, and then sew the vein shut. That decreases our risk of vascular complications for you in the long run, which I think is really important, right? Because you, delightfully, as a neuroendocrine patient, are much likelier to live longer than my patients who have pancreas adenocarcinoma, right? So anything that we can do to risk reduce your operation and extend your survival for as long as we can is great. There are other lesser done operations that you'll hear about certainly, but I think can and should be falling out of favor for a lot of neuroendocrine patients. A central pancreatectomy means that we are removing the center portion of your pancreas that includes the tumor and leaving the head and the tail intact. You don't get any lymph nodes with that. Spleen-sparing distal pancreatectomy, we're removing that back half of your pancreas. We're not taking your spleen, so we're not getting any lymph nodes with that. Enucleation, we're going in and we're scooping out the pancreas tumor. We're not getting any lymph nodes with that. You can sort of see the common theme here. My sense as a surgical oncologist is that if we're going to classify this as a cancer that requires an operation, we should be performing operations that adhere to standard oncologic principles, meaning when I do this operation, we need to be completely evaluating the area in which the tumor grew, right? And that includes looking at those lymph nodes. It involves removing those lymph nodes because if there's cancer cells in them, better out than in. And certainly it can give us an idea about how far this tumor has already spread, right? There are some indications for these lesser operations, but they're pretty specific patient populations in which it makes sense, particularly in patients who may have MEN1, and the expectation is going to be that I'm operating on that pancreas probably multiple times throughout this young person's life. For SBNETs, I think broadly the thing that I can say is they are sneaky and they require a very thorough operation, right? So there's a lot of discussion about minimally invasive surgical techniques, and while there's a role for that, the most important thing, once again, is that we are doing the right cancer operation, okay? 30 to 45% of patients with small bowel neuroendocrine tumors are going to have multiple tumors hiding out in their small bowel. We might be able to identify one of them on the preoperative imaging based on the location of that knot of lymph nodes that we saw in some of those earlier scans, but we are not going to be able to palpate or see the rest of those tiny little tumors on the scans. They're the size of the tip of my pinky or smaller. They can't be appreciated when we do things robotically or laparoscopically. They have to be felt with your fingers. So no matter how this is accomplished, it has to happen with feeling your entire small bowel because all of those tumors need to come out. The lymph nodes need to come out with it, okay? So we need to do an operation that includes all of those lymph node packets that exist along the blood vessels that bring blood to and from your bowel. In this picture from a patient with a small bowel neuroendocrine tumor, you can see that big mass in the middle. That's the mesenteric mass. That sort of spiky thing that we saw on that first CT scan, that's what that looks like in real life. And so it is sucking in all of the blood vessels in the area, and our job is to get that mass and all of the lymph nodes around it out of you. We need to leave at least 200 centimeters of small bowel, okay? Less than that, and I think patients really run into a lot of problems with quality of life. You're spending all day in the bathroom, might be difficult for you to absorb enough nutrients, you may need supplementation. So I measure first and then cut. And then it's also really important to just look everywhere. Like I said, these tumors are really sneaky, and there's a lot of disease that we can find that is not going to show up on imaging, and you're not going to see it unless you really kind of dig deep in there. 20 to 30% of patients that I take to the operating room that have these masses that are identified preoperatively, I find new disease, particularly in the pelvis or in the low parts of the abdomen, that we never would have expected from imaging. It's important. It upstages you, right? You went from a stage 3 to a stage 4 patient. So that's the deal when we have tumors that we're going to take out, hopefully for cure. But I think that surgery, particularly for this disease, is unique because we can offer some help even when the tumor has spread to other places. Symptoms. This tumor can cause symptoms because it causes problems with your anatomy. A lot of patients, as their disease progresses, will develop something called mesenteric ischemia, and that's where that mesenteric mass clamps down on these blood vessels and prevents proper blood flow and drainage from your small intestine. The way that you feel this is that about 30 to 90 minutes after you eat, you develop really significant abdominal pain. That will typically go away with time, but as the frequency of that pain and the severity of that pain increases, a lot of patients will develop what we call food fear, meaning they'll just stop eating because it's too miserable to take in anything because it just hurts. That can lead to weight loss, and that's really debilitating for a lot of patients. And of course, often this is accompanied by diarrhea. Your tumor can often cause problems with actual obstruction. And while with a lot of cancers, we think about obstruction and that tumor kind of being this blockage, right? Like a brick wall for helping or for preventing things from passing. In NETs, it works a little differently because your obstruction is really being caused by that mesenteric mass once again. That thing is always the problem, right? And so what it does is it grabs onto those blood vessels, and as it grows, it squeezes everything and pulls it in, and it causes this kinking of the bowel. And where once your bowel is able to sort of slither like a snake and move everything smoothly through, now it's got these tight twists and turns, and it can't move anymore. And so when you're trying to pass food, liquid waste, things of that nature, it can't get by. Patients are going to have problems passing gas, problems having bowel movements, and then when it's really severe and acute, you're going to have nausea and vomiting, and that's usually what's going to bring you into the emergency room. Hormones, that's what this tumor is known for. That's another good reason to take these out, even in a metastatic setting. We alluded a little bit to the fact that a lot of these functional tumors arise from the pancreas. These are the most common kinds. Insulinoma is the most common. So this is the tumor that's going to secrete large amounts of insulin. Patients are going to have severe drops in their blood sugar. It's going to cause them to have shakiness, sweating, sometimes seizures. They'll pass out. But if they eat, things get better. One of the hallmarks of this, too, is a patient will often come into my office and say, look, I've gained like 75 pounds in the past 6 months. And the reason for that is because they can't stop eating, because if they stop eating, they get sick and they pass out, right? And so patients will come in hundreds of pounds overweight because they haven't had these things diagnosed on time, and that was the cause the whole time. Gastrinomas secrete gastrin. So this can cause acid reflux, GI bleeds, and ulcers. VIP-omas secrete large volumes of this hormone that can cause patients to have large volume diarrhea. And I'm talking about liters and liters a day that can lead to dehydration, inability to keep up with eating and drinking, and severe electrolyte issues. Glucagonomas are far more rare, but you'll hear about them because they create this sort of rash. It's called a necrolytic migratory erythema. It's kind of brown and crusty. It can happen on the face. It can happen on the trunk. And so sometimes patients are identified in this way as having a functional tumor. This is just a graphic representation of one patient, their management journey. They presented with metastatic VIPoma. And I think the things that my takeaways from this patient is that A, surgery can be offered at multiple time points and can be helpful. Every time this patient had an operation, their VIP levels dropped and their symptoms improved. The other thing that I think is really important, as we alluded to earlier, is we don't really know in what order patients should be offered all of the therapies that each of us are keeping in our back pockets. And so it's really important that to get 22-year survival with a metastatic tumor, you gotta have people who are really aware of the new things that are on the market, how to use the things that already exist, and how to work with each other to optimize results. There are studies as well that support use of operation for metastases in patients who have functional tumors. In this set of patients, they had metastatic small bowel neuroendocrine tumors who had carcinoid syndrome, right? This is a classic study. And what they found was, in broad terms, those patients who were able to undergo surgery plus treatment with medical therapy had better results in terms of the symptoms that they experienced in the long run than those patients who were only treated with medical therapy alone. This is the study that I was talking about earlier in terms of thinking about using surgery to prevent future complications, okay? So particularly in patients with small bowel neuroendocrine tumors who may not have symptoms but do have a mesenteric mass present and may have metastases in the liver, so many that we would never be able to address them reasonably with an operation, there might be a role to go into your belly and remove this tumor in your bowel anyway. And one of the studies that supports this notion is this 2020 study that was done by a really smart surgeon in Canada named Julie Hallet. And what she found was that in those patients who undergo an operation in the context that we just talked about, their risk of having unplanned readmissions to the hospital over the next 3 years is significantly lower than patients who have their small bowel neuroendocrine tumors and associated mesenteric masses removed only at the time that they start to cause problems. So it's important to think about, the timing of these sorts of operations, because we certainly enjoy doing an operation when we pick the day and we pick the time versus you rolling through the ER and having to go emergently. Survival in certain studies correlates with resection in well-selected patients. And what I mean by that is that in those patients who are able to undergo an operation and have at least 70% of their disease, primary tumor plus metastases removed, those patients tend to live longer than those patients who are not able to be treated in a similar way. There are plenty of little nuances about the way in which we analyze these studies, which is why we have to be very careful about how we state these results. But I think that in general, if you can have an operation and we can remove most of your tumors, it's probably good to at least consider it. This is a study that we are publishing soon that reports our 25-year results doing pancreatectomies in patients with pancreas neuroendocrine tumors at MD Anderson. And again, what this curve shows is just that in patients who are really carefully selected for the operating room, even when they have metastatic disease and undergo major operations like a Whipple procedure, we can achieve longevity compared to those patients who are not able to be treated in the same way. The thing that we have to be really careful about, though, right, is because I'm not offering you cure and we're taking this huge swing in your belly, we gotta balance the benefits that we're trying to achieve with the risks that we're also offering up at the same time. And you can see at the bottom that patients that have Whipples for pancreas neuroendocrine tumors have an almost 50% leak rate from that connection that we make between the pancreas and the small bowel. And that can wreak a lot of havoc with your recovery from this operation. And so we have to think very carefully about when and in whom we offer these operations to, even though there are a lot of good reasons to offer the operations in the right situation. I'm gonna skip over that one. And then, I think with all of these considerations in mind, you have to sort of create this philosophy at whatever institution that you're in, and everybody kind of has to buy in order to be able to optimize results for our patients. So here are sort of the broad ways in which I think about offering patients an operation and trying to answer this question, should I do the operation? And the first is that we have to keep our eye on the long game, right? So, patients are going to live longer with a pancreas neuroendocrine tumor than a patient who has a pancreas adenocarcinoma. Likewise, patients with small bowel neuroendocrine tumors, even when they've metastasized to other places, meaning spread to either the liver or far away lymph nodes, you're still going to live often a decade or more, right? I drag my feet in patients with metastases before I roll into the operating room. And the reason for that is because it's really important that we understand how this tumor is going to behave. It's great to have a disease where it's often possible to offer an operation in patients who have spread. But if I'm going to go in there, cut away at your liver, burn a bunch of stuff, and then I get that first scan 3 months later and 6 new lesions have popped up, I've done you no favors. We got to save healthy liver. The liver is going to be a problem for a lot of patients with metastases, right? And so we have to create a surgical strategy that allows us to treat the disease, but leave as many healthy liver cells as humanly possible, because you're going to need them in the long run. And then, very broadly speaking, we have to think about, whether or not this operation is going to improve your overall situation. So the way in which Halpern and I often banter about this is, if I'm unsure, if I have a patient with a lot of metastases, and I get this imaging and I take a look and I say, look, here's what I can do. I can get rid of these things. I would leave these things. Is that helpful? And he says, sounds good. They're still getting everolimus. Then I'm probably not going to be that helpful, right? And there's no reason to expose these patients to risk if it's not going to change what he's going to do. And then finally, the intervention should make your life better. If the risk profile isn't favorable, then we just really need to think about what other tools are in our toolbox. Because the goal of treating cancer is not to get everyone to the operating room. The goal of treating cancer is to extend your life at the highest possible quality for as long as we can. So in summary, this is a surgeon's disease. We can operate at multiple different time points, and that's fantastic as far as I'm concerned. NETs are unique and therefore best treated by a multidisciplinary team. Surgery should be considered the standard of care for patients who are of good operative risk and have well-differentiated tumors, and we can sort out the details as we get further into the weeds. And then surgery can provide benefit even when the tumor has spread in other places, but we just have to be really careful and understand how this tumor behaves and what risk we might introduce. Thanks, Mike.